in Percutaneous Therapeutics of adult structural heart disease. We have come the long way from coronary to structural, and now situation is slowly building up. Almost all structural heart problem we could solve with the catheter. Particularly there was unmet need because there are several patients not fit for surgery due to high ST scores. So in structural heart, common conditions are left atrial fibrillation and left atrial appendage closure, patent foramen oval closure, then valve through the transcatheter valve replacement in the aortic position, we all know has grown up very well, and then mitral valve, and then coming to tricuspid valve. So everywhere there is a growth, but slowly in next decade you will see plethora of valves being approved for all positions of the mitral tricuspid, and they will be evolved over a period of time to be useful in all these locations that we already established its role. So coming to left atrial appendage closure, we know atrial fibrillation is one very common and dreaded problem we all face, and we have a situation, a case, suppose whose CHAD score is very high, 7, and has bled score, the bleeding score is 4. This patient we will find it difficult to continue on the anticoagulants, oral anticoagulants, warfarin or NOAC for that matter, because if they develop hemorrhagic bleeding, it will be a disabling stroke. So what are the problems we have? How to prevent stroke in atrial fibrillation? One is therapeutic, the pharmacological intervention, warfarin and NOAC, and second is a closure device for the left atrial appendage. Currently, Watchman is the one which is approved by the US FDA for use. And what we need to look at is the sufficient risk for the stroke if we are convinced, and there are limitations to continue oral anticoagulation, and risk is acceptable, procedural risk is acceptable. No other indication for oral anticoagulation is there apart from atrial fibrillation to prevent the stroke. It's mainly preventing the stroke. So we have large experience with warfarin. On the trial it showed 1 to 3% chance of bleeding, but in the real world the annual bleeding rate was 6 to 8% with warfarin. We know warfarin can be very notorious, and most patients don't follow the INR regularly, so the compliance issue is big with the warfarin. Coming to NOACs were tried, and clearly apixaban is superior in terms of stroke reduction and even in bleeding reduction. So NOAC has taken over, particularly the non-valvular AF. So what do we have? If we have AF, we have several things. We have to control rate, rhythm, and mainly the stroke prevention, that is thromboembolism for stroke prevention, risk factors. These patients have several comorbidities because most of these patients are elderly, and if the CHAD score is 2 or equal to 2 or 2, then we can consider oral anticoagulants. But now, in addition to warfarin, NOAC, we have this option of considering the left atrial appendage closure, which will eliminate the chance of bleeding and stroke. So, and the issues with the oral anticoagulant is almost 50% patients are not taking anticoagulant for some or the other reason. Out of those who take, 30% will discontinue in 2 years because of the compliance issues. And bleeding risk is 2% per year, average bleeding risk is 2% per year in this patient while they are on the treatment. And 90% of the strokes are from dislodgement of thromboembolus from the left atrial appendage. So surgically it was closed, but unfortunately the data available, how good it was and how well it was preventing the stroke. But now, of course, they are collecting the data, so there is a lack of data on surgical closure of the left atrial appendage. So we have come a long way, and we are using Amplat's device, and it's a very simple technique. Transseptal, of course, we have to do transseptal puncture using broken marrow needle, go into the left atrial appendage, inject a dye there, see the shape can be different. So accordingly we have to use, so it's demonstrating the shape of the left atrial appendage is very important by angio, so that we can use the appropriate device for closure. Now device is positioned here under the guidance of team. All these procedures are under GA and guidance of team. And it's positioned here and then gets deployed. After it gets deployed, some patients do get thrombotic thrombus developing on the device itself over a period of time, and that will defeat the purpose of deploying the left atrial appendage to the device. So then there is a reach. We all know that this reach is usually the atrial fibrillation ablation procedure is done around this reach, and which is very close to the left atrial appendage. So when you do a procedure of ablation, usually there is a scar and there may be some erosion which may be prothrombotic. So we have to be carefully deploying the Watchman device in those patients first, and then we can delay the Watchman device deployment. So basically, once the device is deployed, 45 days we continue with the oral anticoagulant and aspirin. After that we do T, and on the T, if we demonstrate that there is no thrombus, no leak, then we can go on DAPT for 6 months. By the time the device will be endothelialized, and then we can continue aspirin for lifelong. So, in last 6,000 patients or 15 years, it has reduced the bleeding risk by 55% and reduced the mortality by 27%, predominantly due to hemorrhagic output due to oral anticoagulant on procedure related. So what do we have? The success rate of deployment is very good, 95%, but with the current Watchman Flex device, which is called as Watchman Flex, the improved device, the implant success rate is 99%, and the complication rate is 2.5%. So it's remarkably reduced. And once this device is deployed, we can discontinue oral anticoagulant in 92% of the patient, and 99% patient will be discontinued after a year. So what are the problems with the device? It can have a very device leak. If it is more than 5 mm, we need to do something about it, then it is significant, and need to close it either by coil or some other technique. And then if you have a device-related thrombosis which can occur in 1 to 6% of the patient, like it is shown here, and then it can get destroyed, and then the purpose of putting the device is defeated. Then we have a device embolization which can occur in up to 2% of the patient over a period of time. You can see this device is lying across the mitral valve in the LV. So basically, after the results of the Watchman, ACC and AHA has given a guideline-based approval to this procedure, and it is 2B, and evidence, the level of evidence B. So it can be done in patients who can be considered for patients with atrial fibrillation, increased risk of stroke, and contraindication from long-term anticoagulation. So this is where we can consider the left atrial appendage device. And indication, as I said, a high Chagrin score, bleeding risk, all these things are very, very important. So now coming to Flex device, which is the latest device, the profile of the device is lower, so it can fit even in shallow left atrial appendage. 1, 2, it is covered so that thrombus is not formed. Plus, multiple struts are deployed so that it gives better seal, so there is no leaking. So overall stability is also good. Number of struts are increasing. So this device seems to be working very well. And there is a Pinnacle study done in America, which says that the 400 patient study done, and the primary endpoint was considered as 5 millimeter leak or more due to at 12 months. So that was not seen at all in all 100% patients of 400 days. And the safety was 0.5%, as I said. Implant success 99%. And the thrombus on the device was 1.8% in new device as compared to 3.7% in the previous Watchman device. So 90% implants have identifiable, don't have any identifiable leaks on 12 months. And compared to the old device, this is far better, and it is used very safely in Flex device. Knowing the results of Flex device, 2 new trials have started. One is option, and second is the champion trial, about which I will discuss in greater detail later. So, who do we consider this Watchman device, and which patient do we consider? With the Chadwick score of 5 and Hasbrouck score of 4, this patient has to go off anticoagulation. So such patient is what we need to look at and then consider if there is a risk of stroke, to prevent the risk of stroke. So as we said, this kind of Chadwick score and Hasbrouck score, the Chadwick score of 7 will lead to 9.6% annual rate of stroke. And bleeding risk with 4 Hasbrouck score, it will cause 8.9%, which is unacceptable for clinical recommendation. So these patients are very suitable for left atrial appendage. Now, initial experience suggested that this device is working very well, no major bleeding during the course of OAC. While 45 days they have to be on OAC after the device is deployed, there was no major bleeding. But there has to be a multidisciplinary approach if we consider left atrial appendage closure. Urologist, gastroenterologist, urologist, and vascular medicine person and cardiologist, of course, should be an IAV person should be available to discuss this case, and on the team should decide whether this case is suitable or not. Then what we have achieved, if we have no oral anticoagulant, oral anticoagulant, then risk of stroke is 12%. With warfarin, it is 4%. With Watchman device, it comes to 2.8%. So some patients do have a recurrent atrial fibrillation despite having a treatment for control of atrial fibrillation. Such patients are suitable for several the atrial fibrillation ablation procedure or surgically, if not suitable for catheter intervention. And this combined procedure can be considered in certain group of patients, but it has to be backed by the trials. So we have to do trial, and these trials will decide. Option trial and champion trial will tell us whether this is suitable or not. But the results of option trial will come in 2024, and champion in 2025. So this is very important development that is happening in terms of in the space of atrial fibrillation and left atrial appendage closure device. So what is option trial? Option trial in one arm is RCT. It's in one arm atrial the AF ablation procedure plus Watchman device, two together, 800 patients. And in another arm the atrial fibrillation ablation plus oral anticoagulant. The result has to be awaited in 2024, and that will tell whether which one to go for. Because using atrial ablation will reduce the number of episodes of atrial fibrillation. We know that it cannot completely cure it, but definitely it will reduce the number of atrial fibrillation episodes. So that also helps in reducing the formation of thrombus, of stroke. Now, another trial which is champion trial, 3,000 patients, and in this there is a Watchman Flex device in one arm, 1,500 patients, and they will be randomized 1-to-1, and NOAC in another arm, and they will be monitored for 36 months, and the result of the trial will come in 2025. And several other trials are ongoing to answer unanswered questions, that these are unanswered issues. Coming to foramen oval, the other important area which can lead to stroke and embolization and paradoxical embolization into the brain, and that can lead to stroke. So PFO incidence in autopsy various age group, it's almost 20, average will be 20 to 25% incidence of PFO in general population. And the annualized ischemic stroke in US are 6 lakhs. And in the world, it is 1 crore 15 lakh patients have annualized ischemic stroke, which is a very large number. And out of these 20% are ischemic stroke between the age of 18 to 60. And these are the patients, 30% of these patients can have a cryptogenic stroke, and 50% will have PFO and 50% no PFO. So these are the patients suitable for left atrial appendage closure, which are young and middle age. And of course at old age also, if they are not if they are sensitive to anticoagulation therapy. So similar numbers are noted in the world also, so it's identical analyzed incidence of cryptogenic stroke. So what do we have epidemiologically? 20 to 25% incidence. Out of that, septal aneurysm, atrial septal aneurysm is seen in 2.2%, and 83% of these patients of aneurysm of septum will have PFO, 83%. So young patient, 50 to 60%, if they develop stroke, 50 to 60% of them will have PFO. And if you go to see if cryptogenic stroke in this age group, PFO is positive in 73%, and some other cause can be there in 27%. So PFO closure also forms a very large area, but it's uncommon to have a paradoxical stroke, paradoxical embolization and stroke. So we have to carefully consider closing the PFO. All patients cannot be closed with the PFO. So incidence of ischemic stroke is 88%. Out of that, 40% is cryptogenic, and hemorrhagic stroke 12%. Now, what are the parameters which can lead to clinical parameters which can lead to paradoxical embolization? One is DVT, migraine, sleep apnea, and of course Valsalva. These are the maneuvers which can initiate the mechanism of paradoxical embolization into the brain. And these thrombi can come from the aortic valve, mitral valve, left atrium, left ventricle, and of course paradoxical emboli. So we have to rule out these sources of emboli completely, and we should be thoroughly convinced that it is only the paradoxical embolus which is causing stroke in PFO, incidentally found PFO. Then those patients can be considered for left atrial appendage closure device. Now, once we have a stroke which is cryptogenic, thorough evaluation is very necessary in terms of echocardiography for structural heart problems. Cerebrovascular disease imaging has to be done in some way, and of course the coagulation pathway has to be studied. We need to also see is there any atheroma which is leading to embolization into the brain and causing stroke. And third is arrhythmia, which is commonly atrial fibrillation. Interestingly, 24 hours monitoring, Holter monitoring will manifest only 2.2% of it. But if we continue the Holter monitoring for 4 weeks, we can detect as many as 15% patient having atrial fibrillation. So how do we study them? We are dealing with the bubble, and if you see the bubble coming on in the left atrium, that means this patient could have a paradoxical stroke if there is no paradoxical embolization causing stroke. If there is no other cause, after studying everything, if no other cause can be explained for the stroke or embolization. There is an interesting disruption, but if his bubbles are crossing into the brain, you will see this disturbance in the velocity flow. And it is being graded into 5. Higher the grade, more is the chance that it could be a paradoxical stroke, paradoxical embolization from the left atrium. So there are now 2 devices which are studied. One is StarFlex, which is called as closure study, and this revealed that there is 51% relative risk reduction, but it is not statistically significant. Whereas RESPECT trial used the Analyzer device for the PFO closure and 73% relative reduction, and this is statistically significant. So comparing the closure and the RESPECT is far better, the Analyzer is far better than the StarFlex device. And ultimate conclusion is closure with is superior to medical therapy alone in 3 specified per protocol as treated analysis. So it has to be carefully assessed and then take a call. All patients cannot be considered for PFO closure. That we have to remember. And a teamwork should be there so that there is no. Now coming to patients having PFO, but some other cause is there. In that, if we close the PFO, there is 45% risk reduction, which is also statistically significant, better than medical management. Similarly, if you have an unknown cause, cryptogenic stroke, as they say, cryptogenic stroke, if we close with Analyzer with the PFO, if it is there, then the 62% risk reduction, which is statistically highly significant. So, in both these arms, it looks like it works. So there is meta-analysis done using this odd ratio, which suggests that transcatheter closure is superior to medical therapy. Clearly. So we can consider closure of PFO not in all patients. Patients of cryptogenic stroke, no other cause is found, and this latest device, that is Watchman Flex, is supposed to be very safe, as stated earlier, very safe. So we can consider this patient for the such patient who have cryptogenic stroke, and there is a PFO, and all this bubble study shows that there is a contrast going from right atrium to the left atrium. That suggests that perhaps there may be a paradoxical embolism from the PFOs, through the PFO. So now coming to the most exciting part of transcatheter aortic valve intervention. In India, there was a Jayadeva did a study of 13,289 patients studied over 13 years with the echo, and that reveals isolated aortic stenosis incidence of 7.3%. And out of that, degenerative was 65%, bicuspid aortic valve 34%, only 1% was rheumatic or any other cause. So active cases which can be considered best extrapolated from our Indian population of 1.35. So active cases every year we have is 281,073 patients for TAVI. But the cost is so prohibitive that all these patients do not get billed any per year at the moment. The TAVI procedures are done to 1,000 and more patients per year. So how does it help? If we leave aortic stenosis without any treatment, on medical treatment, the 50% patient will die in 2 years if they become symptomatic. This is very high risk. But surgical AVR remarkably improve their survival remarkably. But 30% of these aortic stenosis patients are not suitable for surgical because their highest case risk or highest case score or some other issue. So those patients are lying without any on medical management, which is causing 50% mortality. So there was definite unmet need for having a catheter-based procedure which is of low risk. And this is provided by none other than Cribrier, and in April 16, 2002, he deployed a catheter-based TAVI valve under GA in a patient who was very critically in congestive heart failure, and that was very successful. 15 minutes later, patient was extubated, and you can see both of them smiling. And in a short time of 7 years, 3 generations of TAVI valve were produced, and 9,000 patients were done TAVI in 4 RCT. And mortality, when it compared to TAVR and SAVR, is almost equal, no statistical difference at all. And best part is done under the sedation and no ICU treatment. 1 day stay and patient can be discharged. So when it comes to surgical AVR, it is far better procedure and rewarding procedure in terms of coming to long-term durability of surgical valve and TAVI valve. They are identical. Hemodynamically, this is better. The mortality wise, it is better, and stroke rate reduction is significantly better with TAVI. So access is standard access is transfemoral, but if there is an access issue, then we can consider transaxillary, transcarotid, and of course transcaval now or trans-iliac. But nowadays apical and the aortic route is not considered favorable. So coming to partner trial of using sapien TAVI valve and core valve, that is Medtronic valve. One is balloon expander, second is self-expander. And both have shown 50% reduction in mortality in patients who were denied surgery. And those are all very sick patients having a ST score of 15 or more, and several other problems they had. They were not suitable for surgery at all. And if you see the all-cause mortality in TAVR and SAVR is almost identical, but the stroke reduction is remarkably low in the TAVR group, and it is further improving, and this produced a statistically significant difference in the two lines of procedures. Four trials which were done, meta-analysis done, showed the mortality and the stroke both are low, and it produces better hemodynamic, and long-term durability of all is identical in surgical AVR and TAVI. So mortality kept on reducing over a period of years with improvement in technique and improvement in device. So why not consider in low-risk surgical, low-risk TAVI? So patients with ST score less than 4% or maybe 3%, less than 3%. And 3 trials were started in 2014, past 8 years back, and partner, core valve, and motion trial. And results of these trials were highly favorable in favor of having a TAVI rather than SAVI. So it's not something which is very, very remarkably good and cannot be believed. I remember patients roaming all over for surgeon who will operate them, but they were not ready to operate. Those patients were dying. So definitely it has improved the mortality. Now motion trial has clearly shown the surgical valve over a period of 5 years, they were followed, and it showed on echo, it showed that the valve orifice was 1.37 as against with TAVI 1.66, so remarkably better. So orifice-wise, TAVI is superior. Then coming to gradients was much lower in TAVI valve as compared to the surgical valve. And then coming to deterioration in structure of the valve, and surgical valve 26.1% deterioration as against 4% deterioration in TAVI valve. So remarkable benefit with the TAVI, and we all know now only the major problem with the surgical AVR is mismatch, particularly seen in 54% patient with a moderate orifice, and severely narrowed orifice 11%. And this is a major problem in which if it is bioprostatic valve can be done in this patient using TAVI valve. Now bicuspid and tricuspid, another interesting area. So bicuspid and tricuspid valve, in bicuspid valve, the fluoro time and procedure time was significantly higher as shown by P value, but all other, the annulus rupture, root injuries, second valve, paravalvular leak, all these were lower, all these were statistically insignificant, all these features. So even in bicuspid, it is a boon for bicuspid patient, and 1 year mortality is identical, SAVR versus TAVR in bicuspid. In valve, there is a registry which is done, and it particularly used for smaller degenerative valve associated with greater mortality. So depending on the smaller the size of the valve, surgically done. If smaller the size of the valve, higher is the mortality, or intermediate, again mortality is that, but in large, mortality was low even with the SAVR. So valve was tried in this patient with the TAVR, and 30-day mortality remarkably low, 2.7%, 30-day stroke 2.7%, 1 year mortality 12.4%, and pacemaker 1.9% as compared to the redo AVR surgery. So paravalvular leak can be an issue, but it is now remarkably reducing, and with the improvement in the devices. And overall projection is by 2025, we will almost have 3 lakh cases, 3 lakh every year, 3 lakh TAVI valve will be deployed across the world globally. And various devices which are available, currently more popular is Evaluate Pro, and Sapien valve, currently popular, and of course, our Indian valve has also become popular, and these valves are also either FDA approved or CE approved, and they are also being tried in various trials. And as we said, the paravalvular leak can be there, so there is a device, there are several devices which are existing, and new devices have been developed to reduce the leak in a patient who had a TAVI or surgical atypical. Both can have a paravalvular leak, and that can be closed using these devices which are there. So by guideline, who should get a TAVR? All patients above the age of 80 should get TAVR. 65 to 80, they should have a heart team discussion and decide TAVR or SAVR is superior. And every time we see, we should have a primary cardiologist. His opinion is of critical importance. So there is expanding indication for the TAVR, as we see that it is done for the low risk, intermediate risk, and high risk. Now, we knew that STS score more than 15% is inoperable surgically. So all these valves will get a TAVI valve and prolong their life. The very remarkable benefit has been provided to them. And in this TAVI procedure, normally we start with the simple and then go to serious or very complex lesion. Here, we started with the complex lesion. TAVI started with the complex lesion, inoperable cases, and it has proved the test of the time. And when the ST score is high and low, between high and low, we need a heart team discussion to decide whether TAVR or SAVR. So once the patient becomes symptomatic with severe aortic stenosis, then prognosis remains very poor. So if patient has demonstrated by echo and other tests that the valve is severely narrowed or severe aortic stenosis is there based on criteria of 0.8 millimeter of aortic valve opening and gradient of 30 to 40 and velocity more than 4 meters per second. So these patients can be considered for TAVI rather than waiting for them to become symptomatic, because that will prolong their life and you better survive. So this hypothetically it is being constructed like that as young as 40 years old we can consider a TAVI, then second TAVI at the age of 50, and then surgery, and then again TAVI. So this may be a projection at the moment, but future seems to be in favor of this. So who should get TAVI and who should get SAVI? That's the most important question we need to answer. So it's the anatomy, not the age, should determine TAVI or SAVI. So small annulus, TAVI. Unfavorable anatomy with high calcium, LVOT as SAVI. Then bicuspid, low, moderate calcium, no rapid, TAVI. Bicuspid, large annulus, SAVI or TAVI. Any one of the procedure is fine. And but patient with bicuspid, heavy calcium, rapid is there, hydropathy is there. Those patients should be considered for TAVI, SAVI. So coming to surgical intervention, coming to mitral valve intervention, we know that there is unmet need in mitral valve also because prevalence is very high, the incidence is very high, 250,000 cases per year, and prevalence shows that 2 million patients are there, only 50,000 surgery could be done. So there is unmet need for catheter-based procedure, which is for the mitral valve, which is very difficult valve to intervene because the delivery is a problem, fixation is a problem, sealing is a problem, and function is a problem. So there are several devices which have been considered, but lately mitral clip has picked up very well. 42,000 patient deployed mitral valve, and it shows that in heart failure patient, it is much better device to use, and it is better than ICD or for that matter CRT. So selected patient of this mitral clip can be considered, but all other techniques of DMVR are still in the pilot stage. So there is nothing because mortality is very high, 30-day, and 1-year mortality is unacceptable with this procedure. So they are being developed. Coming to transcatheter aortic valve, these are again tricuspid valve. Sorry, and tricuspid valve, TR can be primary or secondary, and there are various devices which are available. Tricuspid valve, leaflet, it can be also, the mitral clip can be used here, or annuloplasty can be done, or orthotropic valve can be employed in the position of the existing tricuspid valve, or the valves are deployed in IVC and SVC to reduce the mortality. So it is called as heterotopic. So mitral clip is also used. So over a period of time, next 10 years, I see that from open chest, it will go to PCI setup in the cath lab, even for structural heart disease. So all in all, there will be a coordinated work between surgeon and the interventional cardiologist with the heart team approach to consider in structural heart specifically to consider any intervention. Thank you very much for your kind attention. I'm happy to have delivered this oration. Thank you.
Thank you, Professor Lal Oration. We won't have any questions. Thank you very much for spending a Saturday morning with us. Though we would have loved to have you here physically, probably next time. We'll continue with this.
Thank you.
Thank you, sir. We'll continue.